thank you. So I'm going to give a hopefully succinct talk on application of infrared reflectance images, and I've changed a few slides just to kind of be slightly controversial about some of the previous talks today. So near-infrared reflectance recordings is going to be obtained by many instruments such as the standard Heidelberg HRA2 Spectralis machine, and using a long wavelength light source that's built into the machine. And we get it as a free image when we do our OCT scans, and with the confocality you can get very high contrast images. And given the session, you can see epiretinal membranes very easily on it with a nice en face. It's not a new technique, and Francois Delory, who developed the autofluorescence devices, also was one of the first groups to look at infrared reflectance imaging. And because of the long wavelength of light, it allows us to look at subretinal structures more easily, potentially. Interpretation of why you get bright and light signals is actually slightly complex, and it's still slightly unclear exactly what modulates it. So there are absorbers of infrared light, including hemoglobin and water, and there are strong reflectors, including melanin. And there's some good work on infrared autofluorescence showing it's melanin that generates that signal, and there are studies comparing the two modalities showing that melanin is a strong reflector. But the signal coming back to the detector is further modulated by macular pathology, deposition, and rearrangement of nice linear structures at the back of the eye that alter the signal. And I'm going to give you examples of that and how we can use to detect quite subtle changes that autofluorescence and fluorescent angiography cannot. So we talked at length about reticular pseudodrusen and the fact that maybe we should call it subretinal drusenoid deposits. And I'm going to give you a counter hypothesis now, because there's a paper that's been kind of ignored. So originally the diagnosis of reticular pseudodrusen was on a blue channel image, and a subgroup of that has a reticular pattern that looks like a net that you can see on infrared reflectance image, and this is the OCT correlate. Now, there's some very careful work from Amani Fauzi's group where they looked at the en face image using the Zeiss machinery to look at the deposition of the reticular pseudodrusen or subretinal drusenoid deposits, and then also on the same machine the reticular pattern on the infrared reflectance image, and then looked at the two. And in contrast to the way that RIC Spade has done it with different machines and using software warping with no masked readers, this was done with masked readers, and they do not superimpose. So the reticular pattern on the infrared reflectance does not correspond to where the deposits are. Very, very careful work. So there is reticular drusen, which is an infrared blue light diagnosis, and there is an OCT finding, and they've got to be related somehow because they occur in the same patient, but they're not the one and the same thing. So I think we should keep both terms at the moment. Again, I've changed the slides just to provoke the last few talks. I showed this yesterday, and this shows the fact that you can use infrared reflectance imaging in the management of your GA patients. And as part of the CAN group, we discussed it, but we don't have enough longitudinal data. And part of the problem, as I mentioned yesterday, eyes with thicker choroid, so this is the autofluorescence image. Oh, let me get the right viewer on here. So this is the autofluorescence image, and this is the infrared reflectance image, and it's bright with a thin choroid, presumably because there is the main reflectance is off the sclera and there's less attenuation. But if you get a thicker choroid, it's a darker image. So there are problems using it for GA alone, and we need to work on this further, maybe to enhance the image, because it's a non-invasive, comfortable test for the patient. And so, again, we have to, although it's good to penetrate through the cataractous lens, which is one of the problems of autofluorescence, and there are some advantages of it, I think at the moment it'll be done both with autofluorescence in conjunction in clinical trials, but not alone at this point in time. There are papers, and this is one paper from an Australian group summarizing just other findings that you can get in AMD patients in terms of drusen and pseudodrusen and geographic atrophy, of which I've highlighted the key features. But there are some diseases where infrared reflectance imaging has an advantage and can be diagnostic unto itself. So looking for angioid streaks, quite often you can pick up angioid streaks earlier with infrared reflectance imaging than autofluorescence or fluorescent angiography. And the notion is that with maybe possibly small breaks in Bruch's membrane where the overlying RP is relatively intact, your autofluorescence and your fluorescein will be normal or near normal, but you will still see the change here on the infrared reflectance image, which is not visible on the autofluorescence image. So it seems quite a nice, exquisite test for many forms of angioid streaks, where you can pick it up quite easily. And also in PXE, peau d'orange is more easily seen. So if you suspect a patient has PXE, an infrared reflectance image is a very nice, quick, non-invasive test that may pick things up. There have been a number of papers from Bertel D'Amato's group on the potential for Naevi monitoring. Given the reflectance of melanin, there have been attempts at using this modality both for tumor monitoring and Naevi monitoring. You get these nice, very bright appearances. It's easy to follow up and quick and non-invasive. The borders are slightly different from that you get from autofluorescence and color imaging. This is a very interesting finding. So in the UK, we're now being kind of forced by an American paper to start screening hydroxychloroquine. And I don't think it's been quite worked out exactly what the right tests to do are for hydroxychloroquine. It's quite a burdensome treatment. And part of the problem is there's a disconnect between, in a 10 to 15% of eyes, between functional abnormalities that you can pick on the multifocal that you cannot pick up on structural tests alone. This is some really nice work by Fred Chen, who's one of our ex-fellows, who's now in Perth, where he showed that in some of the patients where they got this abnormality, this ring scotoma that's present on microperimetry or multifocal electroretinogram, that all the other conventional modalities are normal. With the infrared reflectance image, you get this bright central area. But it's not the bright central area that's abnormal. It's actually the area just outside of it where you get an abnormality in the interdigitation zone. And that modulates the infrared reflectance signal. So it's actually this area in white that's abnormal, and that's where the OCT interdigitation zone abnormality is noted, and the actual bright center is the normal area. So it may be useful in hydroxychloroquine screening, and has actually refocused our mind on what to look at in the OCT and look at structural changes on the interdigitation zone, and maybe some sort of en face of that would help in our screening of hydroxychloroquine patients. And another patient that I'd like to discuss, given our controversy of previous cases, is a 28-year-old female, not a vascular path, with a history of paracentral scotoma that she could draw beautifully on an Amsler grid, and a normal clinical fundus exam, normal autofluorescence examinations. But on the infrared reflectance, she had these dark areas that corresponds perfectly, which is what she drew on the Amsler grid, with subtle changes on the outer retina, but no PAM-like changes. So this, to me, is a separate disorder from the middle retina ischemia, and there, on follow-up, there was no thinning of the middle retina on follow-up. So this, to me, is PAM, is acute macular neuroretinopathy, and there is an overlap of symptoms with some of the middle ischemic retinopathies as well. And just as a last case before I end, just bringing it all together, multimodal imaging. This is a really interesting patient who had, was a Lohmeyer with an idiopathic CNV. We treated that, and about a month after the initial injection where the central vision improved, the patient, who was a graphic designer, described multifocal slight scotomas. So the patient was very visually aware, and they were so interested in their vision, they voluntarily came back to get monthly OCTs. And when they presented with the scotoma, we found these multifocal lesions that had changes on the infrared reflectance that corresponded to changes on the outer retina, these outer retina hyperreflective disturbance. But what was interesting, when we followed this patient over time, again, like the AMN, these were little dark lesions that corresponded to these features. Over 5 months, they completely disappeared on the infrared reflectance and on the OCT, and at 5 months we repeated the autofluorescence and all the other tests, and they had all completely disappeared. So if we picked up this patient at this point, we'd say this patient had an idiopathic CNV, but clearly they had these multifocal lesions that were visible on the infrared reflectance and OCT that subsequently completely disappeared. So a lot of our idiopathic CNVs are probably not idiopathic, and maybe we haven't caught them at the right window. So in summary, near-infrared reflectance allows interrogation of deeper structures. The signal intensity is complex interplay between the melanin and scleral reflectivity and modulated by other structures and regular structures in front of it. And I think they have a very useful diagnostic role in PXE, acute macular neuroretinopathy, and reticular pseudodrusen that may well be different in property somewhat from subretinal drusenoid deposits in Naevi. Thank you for your attention.